Good morning, everybody. Um, I think we're ready to roll. There's people queuing up to get into the meeting, which is amazing. My name's Matthew Costa. I'm an orthopedic trauma surgeon from the University of Oxford and a long-standing member of the Global Fragility Fracture Network. And it's actually a genuine pleasure to be opening this meeting today. And this webinar is about the Simpler program. So better nutrition for better outcomes for fragility fracture patients, something that I've been interested in but inexpert in for a very long time. And so I'm absolutely delighted today to be surrounded by genuine experts. And I'm very, very grateful for Jack and Olaf and the rest of the team for inviting me along to open this session. So as you guys all know, there are going to be a series of 4 webinars around Simpler. This is the first of them. They will be repeated twice on each occasion for different time zones. And the first one is about unnecessary fasting, which is a subject close to my heart. It's something I've been banging on about for a long time. But it still happens, doesn't it? So this Saturday, I was in the hospital doing my operating list, and I had a lady, an older lady with a broken elbow, who was waiting to have surgery. And the way it is in our healthcare system and in my hospital, some people came in with bits of bone sticking out the skin and jumped the queue. So at the end of the day, after a long day operating, I had to go up to the ward and speak to the lady with the elbow fracture and explain to her that she wasn't having her surgery that day and that other people, I'm afraid, had to take priority. And she was remarkably understanding, as the patients are. She said, I understand that people have got worse injuries than mine and they have to be done sooner. But why have you kept me starved all day? And this is the 3rd day on the run that I've been kept starved all day waiting for my operation. And I had my head slightly in my hands and I said, I've got no excuse for that at all. There's absolutely no reason why you should have been starved for 3 days on a run ahead of surgery that you're not even having now. Now, this lady was relatively young and pretty fit. So other than being annoyed about being starved, she's unlikely to come to long-lasting harm from that scenario. But we all know, all of you on this call, that that's the good end of the fragility fracture spectrum. At the other end of the spectrum are the hip fracture patients and other lower limb fragility fractures, average age of 84 in the UK, often with lots of comorbidities, lots of frailty issues. And around half of all of those patients have got malnutrition before they come into the hospital. And when they're in the hospital, they suffer similar things to this lady with the elbow fracture. They get delayed, they get moved around from pillar to post. Despite all of our efforts over the last 20 years of the FFN to try and improve the situation, around the world, patients are still not treated entirely as we would like. And that includes keeping them starved. And of course, if you starve these patients who are already malnourished, their malnutrition gets worse. And that's not just a problem of nutrition, that's a problem of outcomes. We know that their risk of complications from wound healing and so on goes up. Their risk of their inability to get out of bed and mobilize goes up. So their risk of pressure sores goes up. And of course, eventually, that combination of increasing complications and reduced mobility means that they're more likely to die in the months after their injury, if indeed they get out of hospital at all. So malnutrition is not just an inconvenience problem, it's a problem of morbidity and a problem of mortality. So that's why we're here today. The reason I'm such a big fan of the work that Olaf and Jack and the team have done on Simpler is this is a practical guide to how you can actually make things better for your patients in every country around the world. This is not a theoretical framework. It's not a model that looks good in a paper in a fancy journal. This is practical way that you can apply some very simple principles to make the outcomes for your patients with fragility fractures better. So on that note, I'll hand over to Katrina, who's got a simple question, an initial survey for you. For those of you who are worried about interaction, it's just about to happen. Here is your first question. I was desperately trying to vote there, Olaf. Yeah, the system wouldn't let me. I was going to admit to huge numbers of our patients been unnecessarily sort of fasted, but I wasn't allowed to. That it's only for the participants. So we'll give you another few seconds for those of you who are just doing that, and then I think Katrina's going to show us the results, the first big reveal of the day. Just while we're compiling the outcomes there, some of you have already started posting messages in the chat saying hello, good morning. So thank you very much for doing that. If you've got questions and queries as we go along, then please do pop them in the chat. That's super important. Otherwise, we will talk at you, but that's no use to you, really. We want that interaction. We want you to come back with the questions and queries to challenges that we need to address during this sort of webinar. So the results are in. Here's the big reveal. Can you all see that on the screen? I can see it on mine, so I'm presuming yes. So wow, that's I'd love to be surprised by those data, but I'm really not. So actually, around half of you feel that 75% or more of patients have fasted for more than 6 hours and more than once. So that's it just shows my experience here in Oxford is not unique. This seems to be going on all over the world. I'm very jealous of those of you who think it's less than 25%. That's wonderful, well done. But I think the reality is that I think the majority of patients are actually being fasted unnecessarily. And so that's good to have that confirmed at the beginning of the webinar. So on that slightly sobering note, I'm going to hand over to our leader, to Jack Bell.
Thanks so much, Matt, for leading from the front. And welcome everybody. My name's Jack. I'm a dietitian in Australia. I'm beaming in from Queensland in Australia. It's lovely to have you all here. And I'm also an active member of Fragility Fracture Network. And somehow or other, I've managed to got a role in the University of Iceland together with Olof, who's the other co-lead of the original Simpler work that a lot of people have been involved in since then. So what I'll do is I'll just get my screen sharing set up. And there's always this little nervous bit where you go, is it actually going to work? But I'm hoping it will here. Okay, so Olof, can you see my slides here okay? Great. Okay, so I'm here today to talk about Simpler for better nutrition and better outcomes. So that's the we'll say potential or perceived conflicts of interest, but I'd actually like to say these are all acknowledgements. So as I've said, I'm very active in Fragility Fracture Network. Fragility Fracture Network does receive industry partner funding, including from Nutricia, and all the industry partners have had no role in the development, implementation, or evaluation of Simpler. I'd also like to acknowledge all the teams since about 2014 that have been involved in developing what we now know as Simpler. And there's quite a few there, so I'm not going to go through those for the sake of time, but you know who you are out there. And together we are actually making changes across the world to deliver better nutrition and better outcomes. Here's what a lot of people actually don't know, that up to about 1 in 2 of hip fracture patients have one of the strongest predictors of poor outcomes after hip fracture. The reason I'm saying hip fracture, not just fragility fractures, is that's where all of the evidence lies. There's not that much evidence, but there's enough. And it shows that no matter almost how you measure it, and there's some of them just there, you can get the big long list of papers at the end if you like, but there is an absolute overwhelming amount of evidence to show that if you have malnutrition and if you have a hip fracture, then you get worse outcomes. And actually, we've done some studies to show that it doesn't even matter really these days how good Matt is at his surgery or what kind of fancy implant he uses. That's not nearly as effective as looking after the person's nutrition and making sure we don't make them more malnourished than they might already be at the time of being in hospital. So really, it doesn't matter whether you're a surgeon, a nurse, a physio, a geriatrician, a pharmacist, a healthcare assistant. No matter who you are and where you go to work, here's some of the things we all go to work for those of us who work with people with fragility fracture. We want to decrease complications. We want to reduce falls and harmful fractures. We want to help people maintain or improve their mobility. and return to the things they enjoy, improve quality of life, improve the experiences of carers and care providers as well. And that includes people who are healthcare workers. We want to help people get out of hospital sooner, get back to their own homes, live better for longer, keep them out of hospital, and reduce healthcare and community costs. And how can we achieve that? By making nutrition care simpler. What is simpler? Well, let's just go back a little bit before we talk about simpler itself. But we do know from the evidence, and there's actually a couple of nice new publications that I haven't added to this list that some of the FFN members have contributed to. But we know that early interdisciplinary, so that's more than one discipline, so that's doctors, nurses, allied health, for example. Multi-component, which means more than just one thing. There is no silver bullet or no perfect one thing that we can do. Across the continuum, which means it's not just within the four walls of the hospital. And adaptable, which means that what good nutrition care looks like will be determined by where you work, where you live, and who is actually receiving the care. These are all clear, whether it's in books, in reports, in guidelines, in meta-analyses, in empirical literature. It all shows most of the time that this is the best way to do it. So how are we going with that? Well, we did a survey a few years ago now, and we've done a backup one last year as well. And it shows data that's just about as bad as what we saw in the poll at the start. What we do know is that high protein and high energy diets, oral nutrition supplements, and education are routinely recommended in global in international guidelines. But this showed across 308 participants who are healthcare workers from 46 countries in 5 global regions that less than 1 in 5 people who did the survey thought that people received high protein and energy diets, oral nutrition supplements, and education often, nearly always, or always. So we clearly have this thing called a knowledge to practice gap. So people know mostly what they should be doing in terms of nutrition care. Those 3 things I mentioned, they're clearly evidence-based. And if you ask a lot of people, they can tell you these are things that should be done. But there's this evidence, and then there's what happens in practice. And it just isn't happening in many cases across the world. Often that means we're making things too complicated. We know what we should do, but we complicate things in complex healthcare systems. So we figured we better make things a bit simpler. So that's what we've done. So simpler, as Matt mentioned earlier, Professor Costa mentioned earlier, is that it's the simplest solution, which is an implementation program. And hiding in behind this program is actually an awful lot of science, but we've hidden it so that it doesn't look too scientific, because otherwise it makes it complicated. But it's a program that supports early, interdisciplinary, multi-component or more than one thing, across continuum and adaptable nutrition care. There's the link to the main article that shows, or the manuscript that shows how we developed over a 5-year period with a lot of work, engaging sites from different places in the world to come up with what simpler looks like. We started a bit too complicated and we've made it more simple as we go. I won't go through the details of this other than saying it's a traffic light system. Most people with hip fracture don't need a specialist. That's the red section. Most of them need more than just usual nutrition care, which is standard nutrition care, or the small green section. But most people with or at risk of malnutrition who have a fragility fracture, which is the diamond at the top, that's the screening box. If you have a hip fracture, you are at risk of malnutrition. So any of your patients, if they have a hip fracture, the screening tools that are used all over the world for nutrition screening don't work very well in this patient group. And we know around up to half of them are malnourished on admission, and we know nearly every single one does not meet their requirements for nutrition for the first week or 2 after surgery. So you don't need to wait for a nutrition screen or a nutrition assessment. You can just start supportive nutrition care as soon as the person is diagnosed with a hip fracture. Don't even wait until after surgery. And this is where the simpler acronym comes in. It talks about S is for screening, I is an interdisciplinary assessment or reassessment. Now, in many settings, people don't get any care started until there's been a thorough assessment made by a dietitian. That's if you've got one. In most places around the world, a dietitian can't get there fast enough to start care when it needs to start. So it's better off starting some care processes and then tell the patient they're at risk and then do a thorough assessment later. Plan with the patient and make sure the patient knows they're at risk of malnutrition, or if you know their nutrition status, make sure they know. And then implement an intervention or supportive nutrition interventions. You'll see here, we don't tell people what to do because what should be done depends on what is done well in your site and what still needs to be improved. But we've got a toolkit to help you find that out, and that's what these next 4 webinars will be about. Then evaluate the nutrition care provided, which is the E, and then review, redesign, and reform practice. That's almost a little bit complicated, so let's leave that one alone and make it even simpler. This is based on something called the model for improvement, which is how you improve nutrition care in hospitals, and actually how you can improve most things in hospital if you're brave enough to actually do it as a simple improvement process rather than relying on massive amounts of research that sometimes take a very long time and might exclude the very people you need included. You form a team. Get together with a few of your motivated colleagues. Maybe a nurse, a doctor, somebody from Allied Health, 2 to 4 people, not a lot. Set an aim. I won't go through these, but it's not a complicated aim. For example, most people at risk of malnutrition haven't received information, and our aim is next month at least half of the people will have received something, some information that they can understand and is easy to read. Test, choose, and collect measures. Now, this is not research. It needs to be simple. Look at 10 charts, the last 10 hip fracture patients that have come in. If we use that example, did they receive any nutrition information? Or, if you don't like doing chart audits, ask 10 patients with a good memory if they've received any information about nutrition. And you might be surprised how many patients actually, when it's been written in the chart, they don't seem to know or understand. And that tells you there's a problem. Or you can even just ask 10 healthcare workers. Then you can select and test and implement some changes, and that's what we'll be learning all about over the next 4 webinars. And then review and keep going. And if it works, keep doing it. And if it doesn't work, try something else. But here's what I really want to focus on. This is the engine room for Simpler. And it's the Simpler 6 actions. And we have lots of discussions over whether this should be called avoid unnecessary fasting or avoided unnecessary fasting, because a lot of people struggle with the past tense or the fact that it's set in the past. But for effective change to happen in your setting, you need to know that you have a problem. And so the first thing that needs to happen is you need to ask these questions to your staff, to your patients, or to your records and see, has the person or the people, have they avoided unnecessary fasting? Are they aware of their nutrition risk status? Have they received nutrition information? Have they received high protein foods and fluids? Have they received oral nutritional supplements? And do they have a post-discharge plan? Now, these things, you're probably all going, yes, this is really important. And yes, we do this really well. I challenge you at the start of this series to think about and go and ask just a few patients in your setting. You may be horrified at the results if you ask them, if they've got a good memory, how many of these things just do not happen. But the good news is we've got a simpler solution. So it's the quick start guides. And there's a lot of behavior change theory hiding in there. But basically it says for each of those 6 actions, who should be offered the action, how can it be easily measured, and then it gives a list of about 10 to 15 different ideas about what might be some easy things that you could try doing. Well, some of them are easy, some of them are a little bit more difficult, but they are worth it to actually improve that. Again, these are based on a lot of worldwide evidence and behavior change theory. So these aren't just made up, but it's also things that we know sites are already doing all around the world because we're talking to them. We've embedded these into a learning module, which is basically forming the basis for these lectures, these webinars as well. And that's now available, and you can get that from that QR code, or alternatively, if you want to learn more about Simpler, we've just put the main things up on our global hub. We didn't want to overload people with information. So we've got just a few things up there, which is all most sites need to just start making things a bit simpler in their setting for better nutrition and better outcomes. Okay, so at this point, I believe I've just got to check the planner here. And I'm handing over to Olaf, I think, so to talk about what is unnecessary fasting. So over to you, Olaf.
Thank you, Jack. Well, now I will try to share my screen. But hello, my name is Ólöf Guðný Geirsdóttir, and I'm a professor in nutrition at the University of Iceland. Okay, one moment. Here. And today I will try to share a little insight about unnecessary fasting and what it is, who is affected, and how to measure it. Did you get a new slide? Yeah. So unnecessary fasting is when patients are deprived of food or fluids for longer than clinically required, especially before surgery. Guidelines are recommended withholding solid foods for 6 hours and for liquids for 2 hours before surgery. And many hospitals work by the sip to send protocol, where the patient can consume up to 170 milliliters of clear fluids per hour until surgery. And repeated fasting is when we tell a patient to withhold all oral intake multiple times, often due to rescheduled procedures like surgery or inpatient research management. And according to the literature, fasting times commonly exceed the guidelines, often reaching 11 to 19 hours for solids and 10 to 15 hours for liquids in older adults. So who it affects? It's a multi-layer questions, because every single hip fracture patient should avoid unnecessary fasting. It doesn't matter what their BMI is or whether they are formally identified as being a nutritional risk. Hip fracture patients who appear well-nourished can deteriorate quickly when exposed to unnecessary fasting. They deteriorate fast because they are post-trauma, they are post-surgery, they are immobile, many are malnourished before the fracture, and nearly all don't eat enough before and after the surgery. Then, if we look at the other fragility factors and unnecessary fasting, they are also in risk. While this is most important for those screening at risk of malnutrition or are already malnourished, in reality, this group is large and often under-recognized. So And when we look at the healthcare service and unnecessary fasting, we will see high risk of malnutrition and complications. We see prolonged recovery and more workload on the hospital staff and increased healthcare cost. So the key message here is we should not be selective in our thinking. Unnecessary fasting should be considered a risk for all fracture fracture patients. And how can we measure and avoid unnecessary fasting? We recommend to audit charts. Check if the patient fasted for more than 6 hours before surgery or if they fasted more than once. Ask patient with good memory, did you fast for more than 6 hours before your surgery or did you fast more than once? Ask clinicals or your colleagues during team meeting or through a simple online survey. Ask how many or what proportion of our patient fasted for more than 6 hours before surgery or fasted more than once. And now we have a knowledge check. Katarina.
While we're just waiting for people to make the final responses, don't forget you can put questions into the chat as well. So please do that. I think at this stage, the main questions are these individual and combined discussions being recorded and available? Yes, they are, and they will be made available. And we'll also break them up at some stage into smaller sections too, so that they can be bite-sized and put them up on our YouTube site. So, Katarina, are we right to show this data? Is this one that we can show, or is this one of the ones that we just go to the next bit?
Results are on the screen.
What's that, sorry?
You can see the results on your screen now.
Okay.
Okay. So we can't see the answers, how it was answered.
We can continue.
Okay.
Yeah,
Thank you.
we'll just keep going. Thanks.
Okay. So, okay. Then I will just keep going and talk about the significance of. Sorry, I know. I have to share my screen. So I will now talk about the significance of avoiding unnecessary fasting in our practice. As we said before, unnecessary fasting or prolonged fasting can lead to discomfort for the patient, such as feeling of hunger or anxiety, as well as sense of neglect or being forgotten. Older adults are more likely to be malnourished and dehydrated, making proper nutrition care essential as soon as possible. And if we understand the patient perspective, it should motivate us for meaningful changes for the patient and enhance the management of the fasting. The importance of avoiding unnecessary fasting for the patients is because unnecessary fasting can lead to dehydration and malnutrition, which is strongly associated with poor outcomes following hip fracture. It may result in metabolic issues such as hypoglycemia, insulin resistance, and increased protein breakdown. Patients may also experience clinical complications, including delayed wound healing, infections, pressure injuries, skin tears, reduced muscle strength and mobility, and high risk of falls, constipation, and delirium. This is practically harmful for hip fracture patients because they are often malnourished, more likely to experience rapid nutrition decline due to trauma and mobility. They are older, they are frail, and more vulnerable to catabolic stress. Fasting can also lead to discomfort-related symptoms such as thirst, hunger, nausea, and anxiety. Additionally, unnecessary fasting increases the risk of hospital readmission, raises the likelihood of home care placements. Also decrease the quality of life of our patients and heightens the risk of mortality. So, for the healthcare system and the healthcare workers, prolonged hospital it affects also the healthcare system due to prolonged hospital stays and greater need for rehabilitation or long-term care. It increased workload and frustration for the clinical team, more complications and expected readmissions, reduced bed availability and increased pressure on hospital capacity, challenges in maintaining quality and safety standards, as well as meeting treatment timelines, weaker performance in audits and benchmarking studies. By addressing unnecessary fasting, healthcare systems can improve patient outcomes and overall efficiency. So, in summary, if we don't reduce unnecessary fasting time, we will have increased overall healthcare costs due to longer hospital stays, which drive up as expenses, greater demand for staff time, medication, and nutrition support, more frequent use of post-acute rehabilitation and long-term care services, more frequent readmissions and emergency care, reduced patient flow, reduced efficiency, and reduced overall value of care delivery. So we can say, by addressing unnecessary fasting time, we can improve patient outcomes and reduce cost. within the healthcare system.
Thank you so much, Olaf. People often don't change unless they know the reasons why. And so whether you're a patient, a caregiver, or a healthcare worker, hospital executive, or even funders, it's important that we sell that message. So really appreciate that. I'll now hand over to Julie Santi Tomlinson, who's going to bring us all right down to earth with a patient scenario. So over to you, Julie.
Yeah, good morning, everyone from the UK. I'm Julie, and I'm an orthogeriatric nurse by background. Most recently worked in nurse education. And we're just going to do another poll based on a patient scenario that Katarina's going to bring up on the screen in a second. So we have an 82-year-old woman who's been admitted to hospital by the emergency department after falling. And that fall resulted in a displaced hip fracture. So now it's 9 o'clock in the morning, surgery scheduled for 2 o'clock this afternoon. And the nurse notes that the patient has been kept NPO, nothing by mouth, nil by mouth, whatever you call it in your area, for over 14 hours. Because, quote, that's our routine for surgical patients. So the patient's thirsty, anxious, and mildly dehydrated. The anaesthetic team have been asking the nurse to provide, have already asked the nurse to provide clear fluids while awaiting surgery. So we'd like to know which of the following scenarios you can have one choice is the best option for her in terms of how you would normally do this in your own clinical area. So would you allow clear fluids up until she's called for surgery in line with the updated hospital fasting protocol? Would you continue strict NPO, nil by mouth status until the surgery to minimise her aspiration risk? Or would you give a full meal since prolonged fasting is unnecessary? Which of the three of those would you choose based on the current situation in your clinical unit? Let's see what everybody thinks. So we'll just give you a few moments to have a think about that. So you should actually be able to choose one of those options on the screen so that it comes through into the our results. And we'll have the results of the poll in a few minutes. Moments, hopefully, not minutes. And here we go. Okay, so remembering that I asked you to choose what current practice would be at the moment. So it seems that most people would choose option 1, which is, of course, allow clear fluids until called for surgery in line with the updated fasting protocol. Now, given when we go back to the results of the first little poll that we had, and people were saying that they felt that lots of patients didn't receive the correct nutritional care, I suspect that this 85% of you who would have allowed clear fluids, that may not be the case for every patient. So we need to think about that in terms of, okay, so if that's what you think would be the best option for this patient, then we need to be thinking about that being the best option for all of your patients and whether that actually happens in practice. So bearing that in mind for a moment, I don't know if anybody else wanted to say anything else about that result. Jack, do you have anything to add to that?
Yeah, all I'll say is there was a couple of people that did select on give them the meal, and that's probably we didn't give them enough time to show that it was a sneaky time period. It was only 5 hours till the surgery was supposed to be scheduled, and so most places in the world, um, the biggest diet emergency I think we ever get is when somebody's actually given food when they should be fasted for theatre. So that is important because we don't like to lose theatre slots. But it was a 5 hour, so it was less than 6 hours. And then the only other thing I'll say is clearly most people know what to do. And again, it's just showing that we have a knowledge to practice gap. And so
Yeah,
we need to make things simpler.
absolutely. So with that in mind, I'm going to move on to hopefully sharing my screen in a moment. I'm hoping that everybody can see that okay. Yeah, good. Thanks, Jack. Not in the right place on the so I mentioned that my background as an orthopedic trauma nurse, orthogeriatric nurse, and I've been around quite a long time, and I'll tell you that the first report that came out in the UK about malnutrition in older people in hospital was around about the late 1980s. So at that time, I'd been qualified for quite a while, and I was a staff nurse and then a ward sister in the 1980s. And I was having that conversation that we're having now back then. And it doesn't really feel to me that we've made a huge amount of progress in that time. This goes back to what Jack was saying earlier, that it's really, really important that we not only improve knowledge, but we have people who are ready to make change, to make that stuff that didn't happen in the 1980s happen now, because we need to improve the nutrition of older people with hip fracture and other fragility fractures in order to improve their outcomes. So FFN's education offerings and other offerings like this are always focused on improving knowledge, at the same time making sure that we're actually bridging the knowledge practice gap, and that you understand and the people that you work with understand the ways that you can go about making a difference to this really very serious problem that we have. So I'm just going to talk about some of the principles of that for the next few minutes, but there will be a theme of this throughout this programme of webinars and across the Simpler programme and across everything that FFN does. So first question we can probably ask ourselves is what can, and these slides are a little complicated, and I don't want you to get too embedded into all of the detail. Jack wrote them, so you can see he's laughing, and then gave them to me, and I thought, but you know, we'll go with it. There's quite a bit of information here, so I don't want to go into all of it in loads of detail, but I want you to think about the many things that can be done in various different ways to help move this issue forwards, and how really everybody can take responsibility for that. We have a danger, don't we? When we think about nutrition, we think about it as being a specific professional's responsibility, and it's usually either the nurse or the dietitian. And whilst it is their responsibility, it's also their responsibility as part of a much wider interdisciplinary team. It needs to become everyone's responsibility in order to make things much better for patients. So first of all, one of the things that you could think about is how your workflow and systems need to change. So thinking about, okay, whose responsibility is it for prescribing and reviewing fasting orders? And whoever it is that is responsible for that, are they aware of what all of these issues are? Using things like emergency medical record alerts or bedside information that helps to track fasting times much better. If you don't know how long someone's been fasting and it's not very obvious, you're not really going to be able to make a difference. So you could include fasting checks in daily routines, handovers, for example, and meetings. Big things and little things all work. A pretty big thing is ensuring access to food and fluids during delays or in emergency settings. That, you know, we're really not very good at doing that in both an emergency and a trauma orthogeriatric setting. Another option is thinking about appointing fasting champions who can be the ones you have all chosen to come to this webinar today, and it could be that that's because you're really interested in this area, and maybe some of you are the ones that are going to go back to your clinical areas on whatever day it is this week or next week and say, I'm going to be the fasting champion, because we know that very much in my heart, I know that if we can fix nutrition, we're fixing an awful lot of other things to go with it. The second thing that I know is that if we can fix the fasting issue, then we've made a really big step towards fixing nutrition. So this first step is really quite important from that point of view. Secondly, we can look at staff capability. So you will have been educated when you've attended all 4 of these webinars. Some of you have already received a significant amount of information because you've been involved in the programme for a while. But the little things about educating staff on things like appropriating fasting practices, use training case studies or simulations to challenge outdated habits by all means, but also have that conversation with the people that you work with so that you can encourage open discussion and question routine fasting practices, which are part of the problem. And doing things like reinforcing messages through various means. Still on the theme of what can help, so also patient and carer engagement is really quite significant. And there's a thread of this all the way through the Simpler programme. So clearly explaining to patients the reasons for fasting and why it's important, encouraging them and their carers to ask questions, providing written and verbal information, talking to patients about what's going on in their nutritional status and why it's important that they're on board with whatever you're doing, and collecting their feedback's really essential. Some of this is about leadership and policy. So if you are leaders or you work with leaders who have an interest in this area, then in fact, that leadership and policy can support and implement the evidence-based fasting policies that are appropriate for your clinical area. They still need regular reviewing, and someone and everyone need to be looking at things like system efficiency, undertaking audits, sharing the results. And all of this builds towards promoting a culture of what we call continuous quality improvement. And that's fundamentally what this is all about. And then who? I've already mentioned that, you know, there's a danger here that we can, if we're all working in our own silos within our professions, that we don't get very much done. And orthogeriatrics for sure is very much about interdisciplinary working. So, you know, who can help? Let's have a look at it from a service level. Even in pre-admission clinics, ambulance services and wards, there is a really important need to be focused on coordinating care so that we can support early surgery and share clear, consistent information. And a lot of that is about the surgical process when it comes to fasting, understanding how an operating list is going to work and how everybody knows what's happening within that operating list is probably the most fundamental issue with this problem. And that's the thing that may be quite difficult to fix. So we have to have all of the different care teams involved in that. Nurses are with patients 24/7. So they're really quite central in doing things like stopping and questioning unnecessary fasting orders, restarting food and fluids promptly when safe, applying tools to make sure that it's clear who is fasting and how long they've been practicing for. And nurses may be appropriate individuals to lead practice improvement and quality initiatives. Maybe that's something that some of you are thinking about right at the moment. Doctors have the same responsibility, but with the addition of doing things like prescribing, reviewing and cancelling fasting orders. Thinking about fasting as a medical issue is really, really important. And of course, they're quite central in minimising delays to surgery. So if we could all work to not have the situation that Professor Costa was talking about earlier on, where we have patients that are fasted more than once for several periods of time, because we're minimising delays to surgery, we're going to make a massive difference to lots of other things as well. And of course, we know that dedicated orthogeriatric units are really good ways of solving problems, because everybody's focused on the orthogeriatric nature of the patient. Dietitians, of course, are involved, but there are very few of them, and in some parts of the world, not any. So whilst they can be quite central in working with us to solve complex issues, as Jack was saying earlier on, the average, the standard, the everyday majority of patients with a hip fracture, we know are at risk. And we know what the interventions are that we need to do that. And we know that one of them is to prevent prolonged or frequent fasting. So they can help with the solutions in terms of quality improvement, but really it has to be the responsibility of the healthcare staff that are at the bedside every day. And that equally goes for involving things like support services, because support services are involved in the bringing of food, ensuring meals and snacks available at the right time for the right patient, and using systems and tools to increase visibility of the problem and reduce errors. And the same really goes for leadership systems and making and reducing unnecessary fasting a priority, making it really, really central to everything that everybody does. Supporting policy change, investing in systems that enable surgery to happen in a timely manner that everybody understands. And then, of course, patients and the wider community, we need to raise awareness with them and share their lived experience. Just as Professor Costa was talking about a specific patient earlier on, that's the story that you'll hear from quite a lot of patients. So sharing their lived experience with others is a really important aspect of this. So when and where? Well, everywhere and everywhere. Pre-admission, in the emergency department, focusing on minimising fasting linked to the delays that happen in those places, only fasting patients when clinically necessary, linking it up with pain management strategies and identifying those at risk of malnutrition, on the ward while waiting for theatre, things like making sure that we're maintaining safe intake for as long as possible, and making the fasting status visible to all members of staff can be central. Review and update fasting orders, supporting oral intake up to that final moment where you possibly can. And then the big issue of theatre and perioperative care, those planned and communicated theatre lists. You know, I truly believe that that's one of the big things that we have not managed to resolve since my early days in the 1980s. And, you know, we need to be having those interdisciplinary conversations now to see what we can do, even though our health services are very much under pressure. In post-operative care, it's about restarting nutrition as soon as possible, avoiding unnecessary fasting and particularly restricted post-operative diets, monitoring and reporting repeat fasting, and preventing and managing the things that make post-operative fasting happen. And then, of course, again, system policy and continuous policy improvement. And we'll look at this continuously throughout this series of webinars to make sure that you are thinking about how these things can happen realistically. So I'm going to leave it at that for now, and I'm going to hand back to Jack.
Great. And I'd just like to give a good shout out to Mala from Houston, Texas. Oh no, sorry, we've got some responses there as well. So Mala from, I think you are from Malaysia, yeah, as geriatrician in Malaysia. And so, yeah, look, this is a really big question. I put a quick screen dump from AI called Leap Space, just because I'm trying to listen to Julie at the same time, so I couldn't use my own brain across three things. But there is quite strong evidence to show that it is much safer than the alternative, which is to fast people for too long. So the question was around how do we actually support anesthetics to not worry so much about aspiration risk and actually focus, I'll frame this in the positive, and focus on getting better outcomes for patients by providing earlier nutrition. And the sip till send approach has actually really gained momentum globally. But I think my best key learning was from a very senior clinician here in Australia who was very patient when sip till send started. And even though we were leading some work globally in this space, she sat back and waited until the anesthesiologists in our country realized that it was the most important thing to do. And sometimes a bit of patience is more helpful than actually going in really hard and telling people from other professions what they should do or what they shouldn't do. There's enough evidence out there to now encourage people with to say, oh, look, have you thought about this? I'm not the expert in the area, but usually telling people what to do isn't always that helpful. But if we can help them discover that they actually have a need for improvement so that they can get better outcomes, then I think that's probably my key suggestion. Yeah, so sorry for bombarding you with a whole lot of evidence there, but there is, if anybody else has got any favorite papers, please put it in there as well. So I'm now at this point going to go to an activity, I believe. And so, Katerina, is that right? Are you able to share that with me on screen? Otherwise, just tell me if I've got it wrong. Okay, so this is a rating activity. And hopefully you'll be able to just scroll your way down through this. But we're very curious to know, out of some of the activities that can be done, just pace your way through it. It is a bit interactive, and it's more to get people thinking. So it's to get you thinking. It's not even so much to give us any results, but it's more to think, oh, I'm not doing this at the moment, but we could do it or we should be doing it. It is good to, though, also celebrate some small wins, because often people, it can be a bit overwhelming and think we're not doing anything to actually improve the number of people who've avoided unnecessary fasting. But then hopefully as you go through this list, you do find a few things that you are already doing. So if you could please just take the time now to go through this list of things. If it's not working for anybody, please let me know. I do know somebody who came in on a mobile earlier, then came in on a computer and it worked afterwards. So perhaps so if you're on a mobile and it's not working, please let us know. We won't be able to problem solve that this time, but we'll try for the next session, but I don't know if we'll be able to. And if there's something that you really think is a really great thing that is working for you and your teams, and it's not working, it's not written on this list, please just add it in the chat so that we can add it to this list for the next round of people coming through. Okay, Katerina, how many have we got coming through? Does it look like most people have put in their information at this stage, or should we give it a little bit longer? Okay, here we go.
There are the results.
Thank you. So, okay, so is it light blue? Okay, so this is good. So there's quite a lot of the dark blue in the middle, and that's what is, I guess, a useful thing, because it helps us know that although they might not be happening yet, they definitely are something worth thinking about. But it's also great that we are capturing a number of people. Now, I can see we've only had 25 through. So if you are still completing it, please keep completing it. So I'm hoping this will still stay open, even though we've shown up the results here. Is that right, Katerina? Or once we show it, that's it?
Oh, I'm sorry, the poll is closed.
Okay, the poll's closed. All right. Well, we'll learn that for next time. So I'll hold for a little bit longer. Is there I think that's my bad. So apologies for those who are still going through the poll. We've learnt from that mistake, and we'll make sure we get it right next time. If anybody's got any feedback about different components of this webinar, please also let us know. Like if you think the polls are useful, if, for example, this rating activity is one that I'm most interested in know if you had a bit more time, especially if it is something that is worth considering. So at that point, I might go through, I'll scroll down the things that of those who were able to complete. Most often done make it clear who is responsible for fasting orders. And then another one, which it looks like it's quite positive in terms of what's already being done, is supporting patients, families, and carers to ask about fasting, to challenge to see if fasting is really required. And then signs at the bedside to show fasting times is something that either people are already doing or keen to implement. And I'll just check. And then fasting goals is one that it looks like not a lot of people are doing yet, but it is a great opportunity there. And remember, as you heard earlier, the audit doesn't need to be 150 charts. It can just be I don't usually do the ask 10 patients for the fasting ones because they often don't remember too much around time of surgery. So I tend to go with asking 10 staff or auditing 10 charts. And even if you're just looking at repeat fasting, which is a really nice, easy thing to measure, it's sometimes a bit harder to add up the total number of hours, but it's usually very easy to see if somebody's been fasted more than once. So that's a little tip from somebody who's had to do it a few times. So I see there's a couple of questions there, but I will I'll come back to that, Paula. So thank you for putting that question in. And I believe now it's my turn to briefly run through this slide. So if I share. So you've heard a lot about many different things about how to reduce unnecessary fasting. How do we actually make it happen? And this is where you'll get to hear over the next few lectures. And if you do our short course online that we'll give a link to straight after this, you'll see that there's these simpler steps. I went through them briefly in my introduction, but the first one is to form a team. Get together with a few of your motivated colleagues. Again, it doesn't need to be the whole team, just whoever's motivated, whoever's available, and who's willing to get something started. You don't need a big committee. This isn't research. It's just doing what we know should be done. So it doesn't need a lot of paperwork. It just needs some people. I find, now I'm a dietitian, so I probably shouldn't say this, but I always find that if you get a few people in a room and if you have cake or something savory, some pastries or whatever it is, and a cup of coffee or a cup of tea, and just talk for half an hour, even less, 15 minutes, you will actually form a small little team that can actually start doing something simpler. That's the first bit, form your team. The next one is to make the definition. What is unnecessary fasting?
Jack, sorry, but we can't see your slides.
Okay, so I can see them. So I'll just escape out of it again and I'll try sharing another time. Share. How about now? Can you see that now?
Yes.
Okay. Sorry, that was the first one. So form your team. The next one is to define what is unnecessary fasting and keep it simpler. For example, it's a bit hard because if the guidelines pretty much all over the world say 6 hours, it's a bit rude to say somebody's been fasted for too long if it's 6 hours and 1 minute. And so a lot of teams might set it for about 8 hours or even a bit longer, but we do know all over the world fasting times for solids is usually between about 12 and 18 hours. So, you know, if you set the benchmark at around 8 or more hours, that gives an idea. But the problem with using hours is somebody needs to calculate that unless you've got an electronic record that can do that for you. So repeated fasting is often very good because repeated fasting usually is a sign of systemic issues. And so it's quite easy. If somebody's been fasted for more than once, then that's a problem. And if that's happening in most of your patients, then you know that avoided unnecessary fasting is a problem where you work. You don't need to do it for lots of people. The other thing you can, oh, sorry, I'm ahead of myself. So that's the definitions. An aim. This is quite a long aim. It's 6 months because fasting is a hard thing to change. There's not an easy win for fasting a lot of the time. Unless, of course, it's just a matter of changing the opinions of a whole group of professions about what can be done with fasting. But sometimes that can be done quite quickly. But if it's to do with systems or access to theatre, things like that, it can be quite difficult. But let's say the aim could be within 6 months, half or more of our patients will have avoided unnecessary fasting. Now, for many of you, that might actually be a hard thing to achieve. And you might even set an aim that is lower than that. And even though that sounds terrible, sometimes it's important to just start with something. Now, as I mentioned earlier, you can audit 10 charts or ask 10 patients. But I think the easiest way to measure whether or not people are unnecessarily fasted is in your next team meeting. If you've got a team meeting, if you've got some nurses who work on the floor, if you've got a nurse manager or a nurse practitioner or somebody from theatres, for example, a couple of doctors and maybe a few of the allied health professionals, and you either ask them to fill out simple Microsoft forms, which we've got available, or even just hand out a piece of paper, or even just ask them to show their hands. What proportion of people do you think are fasted for more than about 6 hours or fasted more than once? You can get that information in about 20 seconds, and that will tell you whether or not you have a problem. And so there's a few different ways to do that. If you want to know more, feel free to look at our course and we'll give you a bit more details on that. Now, I'm not going to go through all of these. That's a Julie slide. That's like the slide I gave to Julie earlier that has far too much detail on it. So, but what's important is to select, test, and implement a change. Just pick one change, one thing that you can do with 1 or 2 patients and 1 clinician. Not a big change. Don't change the whole world. Just pick something small that as a team you go, let's try this. Try it for half a day. Try it on a few patients. Does it seem to work? Apply these select, test, learn, and adapt type of approaches. In some countries, they're called plan, do, study, and act. That's aligned to the model for improvement. We've changed it a bit because sometimes people don't understand which one's the plan and which one's the study and the act. Whereas if you select something, you test it, you learn, and you adapt it, that just makes sense to most people. We've got a list, again, quite a few there of what are commonly applied across different global settings. And we've got some slightly different ones in our online module, just so that we're mixing it up a bit. But of course, different sites come up with different ideas, which is great because everywhere's different. This is just some ideas to get people started. We are not saying you should be doing all of these things. We're saying pick one thing, try it, see if it works. If it works, continue doing it. If it doesn't, try something else. And then review and keep going. Compare your before and after, learn and adapt. If it helped, keep doing it. And especially tell others. We'd love to hear about it, and I'm sure some of your colleagues in your own countries would too. And then pick the next change and keep going. So in summary on this one, if you want to improve the number of patients who have avoided unnecessary fasting, don't get complicated. Keep it simpler, because we know simpler leads to better nutrition and better outcomes. We've also got the improvement guide, which is the simpler steps that I've just gone through. And for each of the simpler 6, we have a 1-page summary of what it is, who should receive it, and some examples of what can be done. And they're all available from the Simpler Global Hub, which you'll be able to get a link for after this as well. But it's there if you want to take a photo of the screen now as well. And I think that's the end of that, so I'll stop sharing here. And can I just get maybe Julie, can you just scan through to check if there's any other questions at this stage in the list? But now
Sure,
what we'll
Karen?
do is Karen Hertz and I, so Karen's there, just been patiently waiting for this opportunity. We'd love to, in the last little bit of time we've got, in the chat, we'd like you to complete this sentence for us. And we'll have a look at that and maybe make some comments on our favorites as we go through. But so here's the sentence. One small change I think we could test next week. And let's keep it consistent to our topic for today, which is just about avoided unnecessary fasting. So one small change I think we could test next week to improve the number of people who have avoided unnecessary fasting is, put it down there. And if there's something that really annoys you, and you just can't solve it, you can also pop that in there as well, and we can have a brief chance to discuss that also.
I was talking and you couldn't hear me.
All right.
So there's just before your message there, there's a post from Marius talking about he said the problem of unnecessary fasting may actually better be solved or reduced if hip fracture or other fragility fracture patients get priority spot on next day's operating list. And he said he remembers doing that when he was working in Oxford and Sheffield. And there is this whole important thing about the way that trauma lists operate and the way that patients with fragility fractures are listed for theatre and the way that happens. And I suppose, some of that again comes to the need for specialist orthogeriatric care, doesn't it, where everybody's focusing on those things. And I know that'll be something that Karen very much does in her everyday job, is thinks about how important it is to have a dedicated theatre list, because that makes so much difference to how much you can coordinate this kind of stuff, doesn't it?
So I think that what we have on this webinar today are the experts in the people that are attending. And the thing that Jack talks about all of the time is, making things simple and using the resources and understanding what the problems are in your own clinical areas. So definitely, there's been big successes with something in the UK, they often call it the golden hip. So you're identifying people to get on the beginning of a list, to a closer time when that person's going to theatre. So you can manage the fasting issues much more tightly so that people don't need to be fasted for prolonged periods of time. However, and I'm playing devil's advocate here, and maybe I shouldn't be in this setting, but the important thing to remember is we have a finite amount of resources. So we need to make sure that the patients are optimized, and we need to minimize the amount of time that they're fasting, but we also have a limited amount of theatre space. So I understand from a theatre operating time that they want to keep everybody fasting so that they can get them into theatre. But it's a shift in the way that people think. So having systems in place where you have better communication between the operating team and the ward teams, so that we understand what's happening in theatre, when the patient's likely to be going down, when's the last time that they can legitimately eat solid food, when we can keep them with clear fluids. That's about communication. It doesn't mean that everybody's got to be fasted for the whole day and we lose theatre operating time, because that is also an important issue. But then we get into the other realms of, if we start to say, well, we're fasting everybody and we're getting people that are going into theatre with worse malnutrition than they likely came in with, and we know that this group of people, particularly the hip fracture patients, are malnourished when they turn up at the hospital, and we only make it worse. If the systems in the hospital understand by operating on malnourished people, we increase the risks of complications. In the presentation that Olaf did earlier on about things like pressure damage and wounds that don't heal and readmission to hospital, then I think we start to talk about the fiscal implications of malnutrition as well as the physical complications. So it's about communication, and it's about understanding, and this is just my opinion, understanding what the problems are in your own organisation, and then starting to get some smart and measurable goals that you can use the simpler approach to improve patient care. But you know what the problems are in your organisation. We don't know what the problems are in a hospital in Malaysia. I mean, I struggle some days to find out what the problems are in a hospital in Stoke that I go to for 30 odd hours a week. So, I'm not an expert at that, but I think communication, understanding principles, keeping the patient at the beginning, the centre of it, but understanding that we work in a bigger process is really important. Sorry.
I'm talking with my mute on as well. No need to be sorry, Karen. That's really important. I'll just there was a great encouragement, I'll call it, from Elaine from Ireland, I believe, from memory, North Island, I think, who was talking about a relevancy to people from outside of the 4 hospital walls. And yes, it is very difficult to run the fasting one on because it on the outset appears less relevant. But as I've just put in the chat, I think even having people like Elaine here to fly the flag for people from the post-discharge setting, even for this particular course, is so important, because in hospitals, the simplest 6th action is post-discharge plan. Now, I will talk to this up front. These are not covered in this 4 webinar series, mostly because we had to squeeze a lot into 4 webinars. But if we don't get the acute care setting care right, then we don't get the referrals appropriately flowing through into the post-discharge care. Now, we have 2 priorities. I'm not going to unleash what the second one is as part of our simpler strategy for the next 2 years. But one of them is the post-discharge nutrition care. So we've dedicated last year and this year to really focus on the first 5 of the simpler 6. But the next 2 years, well, one of the key things we will be looking at is post-discharge nutrition care planning, because we know it's done terribly. And we know that most of the people who come into our hospitals with a hip fracture or other fragility fractures who are malnourished, they don't get that in hospital. They get that before they're in hospital, and we're sending them home and they're definitely not any better and often worse, and we're doing nothing about it. And so all I can do is apologize, Elaine, that we haven't given it a focus here, but that is actually part of our strategy so that we can actually, it's a long-term game, this one. And the other thing I'll say is that we will go through and cross-check the next 3 webinars to make sure we slot as much examples in there as we can to still make it relevant so that we can keep your voice at the table if that's all at all possible. I'll just check and see, was there any other questions in there, Julie, that's worth... Okay, so we've got... so we've got a small change to test next week is to place a warning sign in the orthopedics ward, avoid unnecessary fasting, and some tips. Absolutely. So thanks, Paula from Brazil. And if it's in the area where everybody is, that's then also going to not only help the staff, but it will help the patients and their caregivers to challenge unnecessary fasting. And I know in our hospital, when people have been unnecessarily fasted, we actually actively encourage them to file a complaint through our complaints system, because that then gets recorded and that gives us more opportunities to then have a stronger business case for more operating scheduled theatre time for our hip fracture patients. And that's been successful in partly, it's not just the only thing we've done, but to secure some dedicated theatre lists. But the patient voice is very strong. So that's another example that I think I could provide as well. Review some charts there. Great. More education on SIP till SEND. So thank you, Monica. That's really helpful. So maybe I'm not sure if I've missed any, but I think because we want to keep these reasonably short, is there anything else people do want to say at this stage? Otherwise, I'll just get Katerina. If you've got one final thing, any other questions people want to ask, just pop it in the chat. There's another 8 new messages I've just seen here. Sorry. Okay, when there's an unnecessary delay, drug supply upon dismissal, how clinic staff may arrange meal provisions that are scheduled. Okay, so I'll use that to springboard it. Often in many hospitals, food service systems are considered a way to save money or a way to, cut some corners and just provide 3 meals a day because that's the minimum standards that are met by a lot of regulations. However, there's a lot of evidence, and we've published a couple of papers recently to show that if you have a very good food service system that is clinically orientated, you get much better intakes and less wastage, and it's a good value, high value investment and return on investment. And so having flexible food service systems, having access to foods after hours, having access to food and drink in the emergency departments, these are some of the areas, for example, that dietitians and healthcare executives can get really actively involved, and the surgeons especially can be very helpful in this regard. Often, if I make noises as a dietitian about our need to get some better resources for better food on the table, it might not happen. But when we've got a whole group of surgeons and anaesthetists and different members of the team who are often sitting at the executive boards, it can be as simple as making a few comments, and then that can help out. So we can all have a role, I think, in actually supporting that. So, Katerina, I might get you to just pop up the... Oh, hang on. There's a great scenario. Elderly patient comes in on Friday with a hip fracture, needs post-operative optimization. It's Monday, Tuesday, it's a public holiday. Wednesday list is already full. How many have the ability to open an extra operating list? Yeah, and that's for the first 10 years of my professional life. So I've been a clinical dietitian in orthogeriatrics now for 30 years. But for the first 10 years, I consistently saw people on the emergency board fasted day after day after day. And once they hit about 10 to 14 days of continuous fasting, because they'd be kept nil by mouth until 11 p.m. And then at 12 midnight, they'd be made nil by mouth for fasting just in case for the next day again. And so they were consistently fasted. Then you'd get an urgent phone call for this very frail, malnourished person who's a refeeding syndrome risk. And by then it's too late. And so being a lot more proactive is very helpful. For this, Having data, exactly. Small audits can be central. Thanks, Julie. Yeah, great. So there's another one about 5 to 7 days. So at that point, I think, Katerina, have you got the final slides to share? Yeah, thank you. It's a pretty easy conclusion, this one for me. It'll be, hopefully we get to see you next week, and it will be around aware of nutrition risk status and receive nutrition information. So again, back to Elaine. So Elaine, I can make sure that we tailor this to include people in the post outside the 4 hospital walls setting. Please do invite your friends or colleagues by sending them the flyer. And yeah, so the links are there. And the next slide, thanks. So thank you. The recordings of this webinar will be sent with a follow-up email as well, so everyone will get that. And if you've implemented any simpler or other changes, please, we'd love to know about this. So there's a QR code there, but also there'll be a link to an activity form that will be sent to you as well. It will only take you about 1 to 2 minutes to fill that out. And if you could give us your feedback on this session by completing the brief survey that will appear on your screen after the end of this webinar. Please, this is the first of 4. So if there's anything that you think we need to do better to improve, we want to hear it. We won't take it personally. We are all about improvement. And so please, any ideas or suggestions, let us know. And I personally would also like to know about the length of time. I know it's very difficult for clinicians to get away for 90 minutes, but we've thought hard about this, and it's probably the way we feel. Well, it is the way we feel to do it because we've done it. But if you think this is too long, please also let us know as well. Okay, thanks all. I think that's the final slide. Yes, just visit the Simpler Global Hub. And again, you'll get links to that. But that's where these resources that we've spoken about and a number of short webinars, short video lectures that cover a lot of this content are all available for free online at the Fragility Fraction Network Global Hub. Yep, thank you. So thanks all for coming. I'll just double check, Katerina, there's no more slides. Great. So on behalf of everybody, as part of the team for Team Simpler, thank you so much. I look forward to hopefully seeing you again next week. See you later for now.
Bye, everyone.
Bye.